painless pelvis swelling for last 2 years. Retinitis and irritation in both the eyes and dryness of mouth with pain in the both ankle joint for last 6 months. Fatigue and generalized malaise for last 3 or 4 months. On examination, revealed pallor with dry eyes, sample test was positive, dry tongue, and dental caries. Bilateral non-tender pelvic gland swelling was noticed, and system examination revealed no gross abnormality. After the initial stage of investigation, we found that there was normocytic normochromic anemia with relative lymphopenia with elevated ESR. Corrected reticulocyte count was normal. CRP was slightly elevated. LFT reveals increased fraction of globulin, and electrolyte reveals hypokalemia, and blood gas revealed metabolic acidosis. Urine REMA was normal. So, depending on the clinical scenario and clinical symptoms and other investigations, we initially sent ANA, which came out to be 4+ positive fine speckle pattern on indirect immunofluorescence study on F2 cells, and thereafter we sent complement assay and ENA profile, which revealed normal C3/C4, negative anti-dsDNA, and high titer of anti-ROLA antibody. So, based on the autoimmune background, we diagnosed our case as Sjogren syndrome. So we have to decide that whether this is a primary Sjogren or secondary Sjogren. So we looked up the diagnostic criteria for primary Sjogren, and we revealed that child had symptoms of recurrent parotiditis, dry eyes with dry mouth, and inflammatory arthralgia with autoantibody positive for anti-SSA, anti-SSB, anti-nuclear antibody, and rheumatoid factor, with certain biochemical abnormalities like leukopenia and high ESR. But parotid gland scintigraphy and minor salivary gland biopsy was not done because the party was not giving consent for these tests. But however, the diagnostic criteria for primary Sjogren syndrome was fulfilled in this patient. And also we found that there are around 9% of patients with renal tubular acidosis can present in a case of primary Sjogren syndrome. So our diagnosis is primary Sjogren syndrome with quite distal RTA. The child was started on oral hydroxychloroquine, prednisolone, subcutaneous methotrexate, folate, and other medications, and the child improved clinically and biochemically and was discharged with advice to follow up in 2 weeks. But unfortunately, the child was lost to follow up for next 5 years. But there is a twist in the tale. The child reappeared in our OPD on 11 March 2022 with complaints of extensive petechial ecchymotic confluent patches over the upper extremity for 2 days and gum bleeding, intermittent epistaxis for the same duration. There was no histopathogenic fever, joint pain, swelling, bone pain, headache, ultrasensorium, pain abdomen, vomiting, bloody stool, jaundice, reddish urine, or no histopathogenic drug intake was present either. On examination, revealed pallor with bipedal pitting edema. The child was tachycardic, and there was confluent ecchymotic spots in the upper limb with gum bleeding was present and dental caries was visible. Bilateral non-tender cervical lymphadenopathy was present with mild hepatosplenomegaly. So we seen the initial investigation, which showed that profound anemia, hemoglobin of 8.1 with normocytic normochromic in nature, and reticulocytosis was present with marked diminished platelet count. That was 11,000 at that moment. DCT was 2+, and coagulogram was normal. Total protein level high globulin fraction. Other investigation was normal. Considering the autoimmune etiology, we sent autoimmune skin and ENA profile. But the child developed overnight profuse epistaxis and shifted to PICU on the next day. And the child was managed with conservatively with PRBC, platelet, nasal packing, and Tranexa infusion. Considering autoimmune etiology and autoimmune hemolytic anemia and autoimmune thrombocytopenia, we started the child on IVIG at the dose of 2 grams per kg over next 24 hours, followed by high dose intravenous methylprednisolone at the dose of 30 mg per kg per day for next 5 days. But at 18 March 2022, the child had clinically significant oozing from nose and new onset petechiae. So we again sent repeat platelet count and coagulogram, but here there was persistent refractory thrombocytopenia. Platelet count was 44,000, very low. So we sent further workup and which revealed active urinary sediments and 3+ proteinuria. Even protein creatinine was very high, 3.6, and 24 hours urinary protein was 2 gram, that was nephrotic range proteinuria. As we sent the complement and ANA profile earlier, and the report came which revealed normal C3, C4, negative anti-DS DNA, positive anti-Rho, and non-reactive APLA profile. So we are getting a picture of refractory thrombocytopenia, significant proteinuria with normal C3, C4, and negative anti-DS DNA. So considering the active nephritis and thrombocytopenia, we performed nail biopsy on 21st March 2022. So what could be our next choice of immunosuppressant? Considering refractory cytopenia with nephritis, we started the child on rituximab at the dose of 750 mg per meter square for 2 doses 2 weeks apart. And nail biopsy report came with surprisingly so combined focal and membranous lupus nephritis +3 and +5. The child was discharged on oral prednisolone, hydroxychloroquine, and elaftil and asked to follow up at OPD. So the current scenario is autoimmune thrombocytopenia refractory, which are refractory in nature, with hemolytic anemia, with relative lymphopenia, active lupus nephritis, positive ANA, but normal C3, C4, and negative anti-DS DNA. So we searched up the literature and found an entity called Momogenic Lupus, which is a rare variant of lupus that occurs in patients with younger age group, less than 5 years, single gene defect, with presence with early renal involvement and focal CNS involvement, but with normal C3 and negative anti-DS DNA. It can also be caused by inherited complement deficiency like C1q, C1r, C1s, and C2, which was the early component of the classical complement pathway, and caused by some single gene mutation like TEX1 gene, DNA, S gene. So we thought of if there was any link between primary Jogren and SLE. So again we searched the literature and found in a study of 100 patients of primary Jogren syndrome, among them 15% could be classified as having SLE after a follow-up period of 10 years. Also, the patient of primary Jogren syndrome who are presenting with extragranular manifestation of pleuropericarditis, glomerulonephritis, and focal CNS lesion can develop SLE in a long run. So a month later at OPD, the child came in a hemodynamically stable condition, and investigation showed the resolution of the thrombocytopenia and proteinuria, with the child was thriving well and doing well, and other investigations are completely normal. So considering monogenic lupus, we sent serum CH50 level and planned for whole exome sequencing, and serum CH50 level came out to be low, 42.28, and that was below the normal range. So our final diagnosis is query monogenic lupus presenting as primary Jogren syndrome, as the whole genome sequencing report is still pending. The child is doing well, and her mother told that that child is a keen dancer and she will attend the dancing classes soon. And what we learned from our case, that SLE can predate primary Jogren syndrome and evolve over time to manifest. And if there is younger age of onset with prominent renal and focal CNS features with normal C3, C4, and negative anti-DS DNA, always consider monogenic lupus. Thank you. Thank you, WBAP, for giving this platform to presenting this case, and special thanks to Dr. Suparna Guha ma'am and Dr. Kaushik sir and Dr. Neena Ghosh ma'am, with Dr. Ayan Das Gupta and Dr. Hasim Sheikh for constantly guiding me to solve this case and present this. Thank you. Thank you, everyone.
Thank you, Dr. Kaushik, for presenting a very unusual and complicated case which you have worked so well, and including the literary research. But at the onset, was there any renal? No. There was no inherited hypertension. At the time, there was a but when the child presented, heavy proteinuria, was there any associated edema or another?
There was bipolar edema only. That is for bipolar edema. There was not very common, but bipolar edema was still there.
The child was still non-tensive. Child was normotensive.
Yes. I mentioned the blood pressure.
The child was normotensive. There is no evidence of hematuria, only heavy proteinuria was there. So we call it nephritis or nephrotic.
Nephritis. It was evening report showing 18 to 20 RBC was there.
Madam, the heavy proteinuria usually goes towards nephrotic. Heavy proteinuria.
Yes, but there was no hypertension. With as the RBC was showing plus evening creatine ratio was very much high.
onset of renal systems ছিল না later on the child presented with heavy proteinuria. So I wanted to know whether the child was hypertensive at the onset or at the time of subsequent presentation with penile edema. So he told that the child was normotensive and there was heavy proteinuria. So there was no mention about hematuria. Yes. I'm telling that whether we should call it a nephrotic syndrome or nephritis.
There was no periorbital puffiness or there was no progression of edema. And urine output was normal. There is no dipping of the urine output. There was no oliguria was not there.
Dr. Suparna Guru, would you like to comment? Please come to the dais because the virtual.
So the thing is that the child had active injury test, 18 to 20 RBC blood factor together, which has no nephrotic base. So, madam, actually, madam, Lupus class 3 and 4 basically presents more of a nephritic
picture.
Class 5 is more of a nephrotic.
Yes, I understand.
This was a mix.
There was a heavy proteinuria without
Three and five together.
the child was normotensive.
Three and five together.
Thank you.
If there are any more questions, the audience will join in through virtually. Please write in your chat box and we'll try to answer them accordingly. Thank you, Konish, for that beautiful presentation. If there are no more questions, we would move on to the second speaker. The second speaker is Dr. Shabnam Molli, who will be talking to us about the stranger in the backyard.
Slide shows. Yes, for a second.
Sir, is it visible? The slide is visible.
Unmute করা আছে। Slide. This for slides visible.
Slides are not visible.
আসছে না?
Slide গুলো আসছে না।
Animation কি কিভাবে আনবো?
স্টপ শেয়ারিং করে আবার এই করো। স্টপ শেয়ার করে আবার করো। স্যার যেটা বললেন
বড় স্টপ শেয়ার করলাম। এর সমস্যা হচ্ছে এখানে। স্টপ শেয়ারের পর
ওনাকে জিজ্ঞেস করো দেখতে পাচ্ছি না।
তার মুখে কোথায়
শেয়ার স্ক্রিন
আমি দেখতে পাচ্ছি there's no slides.
আসছে
না স্লাইড এখন তো আমি করব করার পর ফিনিশ করে শেয়ার স্ক্রিন সব নম্বর
ম্যাম
আসছে দেখুন আসছে
Good afternoon, everyone. Myself, Dr. Shabnam Molli, second year postgraduate trainee in this institution. Today, I am going to present an interesting case titled "Stranger in the Backyard." This story starts
back on April 2019 when when a 7-year-old girl was suffering from persistent fever, rash, and recurrent abdominal pain, for which there were multiple hospitalizations, and she was treated conservatively. With the similar symptom, on November 2019, she was admitted to this institution, and her serum amylase lipase were raised. CCT abdomen showed features suggestive of acute edematous pancreatitis. To find out the causes, we did various investigations, and the infective and surgical causes were ruled out, and further investigation showed a positive anti-nuclear antibody in a titer of 1:640 with positive anti-DS DNA with normal C3C4. So the patient was diagnosed with SLE pancreatitis. Subsequently, she developed macrophage activation syndrome, for which she was treated with methylprednisolone pulse dose at a dose of 30 mg per kg, which was followed by oral prednisolone with taperin, and oral hydroxychloroquine started after an eye examination, which was absolutely normal. After that, there was a loss of follow-up for a long period due to the COVID pandemic situation, and on March 2021, the child again returned back, this time with a different symptom, with facial puffiness with reduced urine output. Her urine examination showed active urinary sediment, and the 24-hour urinary protein was significantly high. We did a renal biopsy, which showed a class 4 lupus nephritis. We started treating the child with cyclophosphamide pulse therapy at a dose of 750 mg per meter square as per the NIH protocol. Unfortunately, thereafter again, there was loss of follow-up. Meanwhile, in July 2021, she was admitted to a local hospital with generalized tonic-clonic seizure, altered sensorium, and visual hallucination. She was found to be hypertensive and was diagnosed as hypertensive encephalopathy. Brain imaging facilities were not available at that place, so we couldn't say whether it was a posterior reversible encephalopathy syndrome or not. She was treated conservatively and discharged. After 3 weeks, when she came back for getting the second dose of cyclophosphamide, because of the long gap, we have to restart the entire schedule again. We did an MRI brain at that time. There was no ischemic or hemorrhagic changes. But in T2 flare sequence, there is a significant hyperintensity in the left occipital cortex just behind the parieto-occipital sulcus. According to radiologist, it could be due to the postictal edema. Again on December 2020-21, when she came for the 5th dose of cyclophosphamide, she complained of headache. For evaluation, we did an MRI brain, which was normal, CSF study done, which was again normal, and BP was controlled at that time with antihypertensive. And so the child was sent for ophthalmic examination. Then the Pandora's box opened. Dilated fundoscopic examination showed there is a gross temporal pallor on both optic discs and with mild arterial attenuation and without any edema. But surprisingly, she had no visual complaint. Her color vision according to the Ishihara's chart was normal, and her pupillary reaction, anterior segment, intraocular pressure, all normal. But the Humphrey's visual field showed inferior altitudinal defect in the both eyes with few scotomas in the left eye. Repeat ophthalmoscopic examination done after 2 months, that is on February 2022 and on April 2022, which showed the same findings. Visual field defects persisted too. OCT shows no significant thinning in the retinal and optic nerve layers, but the data is inconclusive because in our hospital, the database was for patient aged more than 18 years. And as we all know that the nerve fibers reduces by the age, so what is normal for adult may not be normal for children. And here we can see that there is significant difference in the nerve fiber thickness between the two eyes, which also suggests an optic nerve damage. We did an MRI orbit and brain, which showed a bilateral optic nerve hyperintensity. According to radiologist, it could be due to demyelination or could be due to inflammation. We did further investigation, which showed a bilateral prolonged P100 latency and decreased amplitude in the VP, and the anti-aquaporin, anti-MOG antibodies were negative on 2 occasions done 3 months apart. Anti-phospholipid antibodies were persistently negative since 2019. So what is the cause of the optic nerve pallor? Is it due to hypertensive optic neuropathy? In case of hypertensive optic neuropathy, the lesions are generally reversible, but we got the lesion in repeated ophthalmoscopic examination, and there was no retinal changes, no retinal arteriolar defect. So this possibility is ruled out. For infective causes and infiltrative causes, we did various blood investigation. Infective serologies were negative, and there was no feature suggestive of infiltrative causes. Is it due to neuromyelitis optica, multiple sclerosis, or edema? MRI feature shows no features of MS or edema, and as I have mentioned earlier that the anti-aquaporin and anti-MOG antibodies are negative, there is no neurodeficit and no features suggestive of cord compression. So these possibilities were again less likely. There was no history of trauma, and according to MRI and clinical examination, there was no features suggestive of any compressive disorders. So, ruling out all these potential possibilities, we came to a conclusion that it could be due to SLE optic neuropathy, which can again be anterior ischemic optic neuropathy or optic neuritis. In case of AION, usually APLA antibodies remain negative, so it could be optic neuritis. So, coming to the discussion, ocular manifestation occurs in about 1/3 cases of pediatric SLE patients, and the most common form was cotton wool spots. But optic neuropathy is very rare. More so in the pediatric population, it occurs in approximately 1% cases. The possible pathophysiology is the occlusive vasculitis of the small arterioles supplying the optic nerve, which in milder cases cause demyelination and in severe cases cause axonal necrosis. Majority of them are seropositive for antiphospholipid antibody, and neuromyelitis optica antibodies are also present. But very few cases have been reported which were both APLA and NMO negative. One such cases was reported from PGI Chandigarh on 2016. Majority of optic neuritis are painful, but again painless cases have also been reported in literature. So why the child was asymptomatic? Because transient vision loss may not be appreciated in children properly. And the child was already getting cyclophosphamide and steroids, so which are also used in the case of treatment of optic neuritis. So possibly there was a rapid visual recovery. This rapid visual recovery can also be explained by the phenomena of neural plasticity, as we found after extensive literature search. So the take-home message will be routine ophthalmic examination should be strictly performed in all pediatric SLE patients without any apparent visual symptoms for early detection and treatment of any blinding complication. Thank you. Any questions from the judges, from the audience? Yes, sir. Yes, sir.
This is actually, apart from this, it's a very nice case. But as an endocrinologist myself, Dr. Ajitesh Rai, I'm an endocrinologist in this institution. But any patient with hypertension, if we see PRES, apart from SLE, this is absolutely another case. But sometimes a patient may present with two diseases. So it is our dictum that any patient with hypertension with PRES or resistant hypertension or hypertension which is refractory to multiple drugs, we have to exclude pheochromocytoma even in the childhood age. So particularly the genetic syndromes like succinate dehydrogenase, SDH, B and D, VHL, they may present with similar type of problems with severe headache with PRES. But actually this is true that they will not present with optic atrophy, rather we can see papilledema in that cases. But anytime in our practice, if we see refractory hypertension, even in this age group with PRES, you have to do urinary metanephrine and non-metanephrine. It is my comment. But this is a very wonderful and interesting case.
Thank you so much for your input. If there are no more questions, we'll move on to the third speaker. Thank you. Thank you, Shabnam. Our third speaker is Dr. Anuj Datto, who will talk on deep sea diving. Yes.
Share screen. স্ক্রিন শেয়ারিং টু ওয়ান স্টপ শেয়ার করে আবার স্টপ শেয়ার করে করতে হবে Screenshot.
One share on the right.
Namaste. ये করে দিচ্ছি।
Good afternoon, respected sir and ma'am. I, Dr. Anuj Datta, second year PGT from VIMS, Kolkata. Title of my talk is today, Deep Sea Diving. A 2.9 kg outbound male unit born at a gestation age of 39 weeks by vaginal delivery was transferred to our NICU with a chief complaint of respiratory distress at day 5 of life. According to the parents, the baby had respiratory distress since 4 hours of life and was shifted to different hospital where the baby received head box oxygen and IV antibiotics. No documented resuscitation notes were available. On admission, the baby was assessed and airway was normal, no added sound noted. Baby had respiratory distress with tachypnea, retraction and a saturation of 85% in room air. Circulation wise, the baby had a prolonged CRT of more than 3 seconds and a heart rate of 165 per minute. On initially, capillary blood gas analysis showed mixed acidosis with a pH of 7.26 and a PCO2 of 55 and a base efficient of -8. Chest X-ray revealed pneumonic changes. Initial CPAP trial was given, but baby deteriorated and it failed. So baby was intubated and put on ventilator. Sepsis screen and blood culture was sent and IV antibiotics were started as per our NICU protocol. After initial fluid bolus, baby was put on maintenance fluid. Within 6 hours of admission, baby had a convulsion. So IV phenobarbital was started and further investigations were sent for neonatal seizure as per our unit protocol. But lumbar puncture could not be done as baby was unstable and IV antibiotics were upgraded. Notable findings from the investigation since admission was that of serum sodium, and the serum sodium was 153 millimole per liter. Blood glucose, serum calcium, serum magnesium were normal. So we managed this high serum sodium as per hypernatremic dehydration, probably due to hypovolemia. Then, despite optimization of the fluid, serum sodium persistently remained high after 24 hours, and the serum sodium level noted was 159 millimole per liter. Other electrolytes were normal, renal function tests were normal, cranial ultrasound revealed increased subarachnoid space. At day 7 of life, with rising serum sodium level, we decided to correct the hypernatremia over 48 hours with N/6 solution as depicted by the formula below. The water deficit for this baby was 0.15 liter and replacement volume was 0.18 liter. This replacement volume of 0.18 liter was given over 48 hours. After 48 hours of correction, no significant improvement were noted despite stable hemodynamics. Rather, the post-fluid correction serum sodium level noted was 165 millimole per liter. And also during this course, baby improved respiratory wise and could be extubated and put on high flow nasal cannula oxygen, but a jerky breathing pattern was noted.
একটু ইন্টারাপ্ট করছি, স্লাইড চেঞ্জ হচ্ছে না কিন্তু
শেয়ারিং স্ক্রিনটা দেখাই যাচ্ছে, স্টপ শেয়ার করে আবার
স্লাইড চেঞ্জ হচ্ছে না।
ওকে স্যার,
স্যার একবার আমি করছি, স্ক্রিন শেয়ার করছি। দেখা যাচ্ছে
Sir, should I start from the beginning?
স্লাইড শো করো আগে, স্লাইড শো করো।
স্লাইড শো ইসে করা আছে
না, করা নেই। নেক্সট স্লাইডে যাও।
কি হচ্ছে
আগে স্লাইডটাকে ওপেন করে নিয়ে তারপরে স্ক্রিন শেয়ার করে স্লাইডটাকে শেয়ার করো। আগে স্লাইডটাকে ওপেন করে নিয়ে মিনিমাইজ করো। প্রথমে দেখিয়ে দিলাম তো।
না না ওখানে তো দেখাবে।
স্লাইড শো করো।
হ্যাঁ স্যার। আসছে স্যার।
স্লাইড শো হচ্ছে না, তুমি পেজ ডাউন দিয়ে তাহলে পরের স্লাইডের উপরে যেখানে ডিপ সি ডাইভিংটা দেওয়া আছে ওখানে ডবল ক্লিক করো তো একবার, মেন স্লাইডে এসে।
হ্যাঁ স্যার আসছে।
হ্যাঁ ডবল ক্লিক করে পেজ ডাউন দাও।
হ্যাঁ স্যার আসছে।
না
আসছে না।
স্লাইড চেঞ্জ হচ্ছে না, আগের দুটোতে তো হলো।
এক মিনিট। এখানে যাই না। সমস্যা এবার আসছে দেখাচ্ছে।
না না এবারে তো তোমার তো ফোল্ডারটা দেখাচ্ছে, তো আইপি ফোল্ডারটা।
কারেন্ট স্লাইড করতে কিছুই দেখাচ্ছে না স্যার।
না শুধুমাত্র ফোল্ডারটা দেখাচ্ছে। আগেরটা কিভাবে করলো? আগের দুটো তিনটে প্রেজেন্টেশন তো হয়ে গেল।
হ্যাঁ বললাম তো। হ্যাঁ স্যার বললো যেটা
আগে আমি আবার বলে দিচ্ছি।
হ্যাঁ স্যার এক মিনিট স্যার বারবার। আচ্ছা ওকে ঠিক আছে। হ্যাঁ ওকে ওকে আচ্ছা এটা করলাম তো এইটা স্যার। ওকে আসছে স্যার এবার।
হচ্ছে না, সমস্যা হচ্ছে একটু।
আসছে স্যার। হ্যালো মিউট করা আছে কেন?
না এটা তো ঠিক আছে, স্লাইড শোটা হচ্ছে না, আমি পাশে দেখতে পাচ্ছি সবকিছু ঠিক আছে। তুমি নেক্সট স্লাইডে যাচ্ছ যখন তখন সেটাও দেখতে পাচ্ছি না। তুমি মাউস মানে মাউস কন্ট্রোল করে সেকেন্ড স্লাইডে যাও।
এবার আসছে
না ডবল ক্লিক করো, মানে স্লাইডের উপরে ডবল ক্লিক করে পেজ ডাউন দাও। তোমার কিবোর্ডে যে পেজ ডাউনটা আছে পেজ ডাউনটা দাও। এখানে হচ্ছে না
স্যার। আমি কি একবার জুমটাকে এ করে করবো?
জুমটাকে করতে যাও না, জুমটা করতে গেলে আবার ঢোকাতে গেলে খুব মুশকিল হয়ে যাবে। আগেরটা হলো কি করে?
একটু বলছি কি ভার্চুয়ালি কজন লগ ইন করেছে সোমনাথ?
এখানে তো 20 জন ছিল, এখন 16 এসছে। এবারে একদম ঠিক আছে, একদম ঠিক আছে, এবারে একদম ঠিক আছে।
চেঞ্জ হবে। এটাকে ঘুরে একটু এদিকে নিয়ে যাই, এখানে নিয়ে যাই, সেটাই ইয়ে করো।
আমার এখানে চেঞ্জ হচ্ছে না।
তোর এখানে চেঞ্জ হচ্ছে, তো কেন হচ্ছে? তো হচ্ছে।
Sorry for the technical glitch. I will be beginning from the beginning of the talk. I will start from the beginning of the talk. Good afternoon, respected sir and ma'am. I, Dr. Anushatta, second year PGT from WIMS, Kolkata. Title of my talk is Deep Sea Diving. A 2.9 kg outbound male neonate born at a gestation age of 39 weeks by vaginal delivery, was transferred to our NICU with a chief complaint of respiratory distress at day 5 of life. Baby had respiratory distress since 4 hours of life and was shifted to different hospital where the baby had received head box oxygen and IV antibiotic. No documented resuscitation notes were available. On admission, baby was assessed. Baby was normothermic, airway was normal. Baby had respiratory distress with retraction, tachypnea, and a saturation of 85% in room air. Circulation-wise, the CRT was prolonged and heart rate was 165 per minute. Initial capillary blood gas analysis showed mixed acidosis with a pH of 7.26 and PeCO2 of 55 and a base deficit of -8. Chest X-ray revealed pneumonic changes. Initial CPAP trial was given, but it failed. So baby was intubated and put on mechanical ventilator. Sepsis screen and blood CS were sent and first-line IV antibiotics were started as per our NICU protocol. After initial fluid bolus, baby was put on maintenance fluid. After 6 hours of admission, the baby had convulsion, so IV anticonvulsant phenobarbital was started. And further investigation were sent for neonatal seizure as per our unit protocol, but lumbar puncture were put on hold as baby was unstable. IV antibiotics were upgraded. Notable finding among the investigations sent since admission was that of serum sodium, and serum sodium level noted was 153 millimole per liter. Blood glucose, serum calcium, serum magnesium were normal. We manage this high serum sodium as hypernatremic dehydration, probably due to hypovolemia. Despite initial optimization of the fluid, serum sodium remained persistently high for the next 24 hours and the serum sodium level noted was 159 millimole per liter. Other electrolytes level were normal, renal function tests were normal, cranial USC showed increased subarachnoid space. At day 7 of life, with a rising serum sodium level, we decided to correct the hypernatremia over 48 hours with N/6 solution as depicted by formula below. What we calculated the water deficit, which for this baby was 0.15 liter, and replacement fluid for this baby was 0.18 liter. This 0.18 liter replacement fluid was given over 48 hours. After giving fluid correction for 48 hours, no significant improvement in the serum sodium level was noted despite improved hemodynamics. Rather, the post-fluid correction serum sodium level after 48 hours, serum sodium level was rising and serum sodium level noted was 165 millimole per liter. And also during this course, baby had improved respiratory wise and could be extubated and put on high flow nasal cannula oxygen, but a jerky breathing pattern was noted. CSF study was normal. So we started looking for other possible causes of hypernatremia. The question that struck our mind at that point was, are we missing something? So we took a step backward and re-evaluated the case to find the missing link in the case. Meticulous urine output measurement revealed polyuria with a urine output of more than 6 ml per kg per hour. Are we dealing with neonatal diabetes insipidus? After consulting our endocrinology department, we sent for paired serum osmolarity, urinary osmolarity, along with serum sodium level were sent, and the test result revealed urinary osmolarity of 119 milliosmol and serum osmolarity of 340 milliosmol. With serum osmolarity more than 300, urine osmolarity less than 300, so we were dealing with a case of neonatal diabetes insipidus. So therapeutic challenge with oral desmopressin was started at a dose of 50 microgram every 12 hourly, and appreciable change post desmopressin treatment was noted. Pre-treatment serum sodium was 156 millimole per liter, and after 24 hours of treatment, the serum sodium was 153 millimole per liter. And after 48 hours of treatment, the serum sodium level dropped further, and it was noted around 143 millimole per liter. And polyuria also got corrected. Since the baby had responded to the oral desmopressin, so we were dealing with a case of central diabetes insipidus. After initial stabilization of the serum sodium level, we gave a 24 hours of desmopressin-free period as per standard treatment protocol. And serum sodium again showed rising trend during that 24 hours of treatment-free period. That led to our conclusion that this is not a transient phenomenon. During the treatment period, the serum sodium and urine output were monitored meticulously, and gradually the desmopressin dose was tapered and continued at a stable dose after due titration of dose under the guidance of our endocrinology department. If we look back into the diagnostic workup till now, we had come into 3 conclusions. First, that we were dealing with a neonatal diabetes insipidus since serum osmolality was more than 300 and urine osmolality of less than 300. Since the baby, second conclusion, that since the baby responded to oral desmopressin, so it was a case of neonatal central diabetes insipidus. And with a third conclusion was that with a desmopressin free 24 hours period, there was a rising trend in the serum sodium level. It showed that it was not a transient phenomenon. So next question was, what was the pathology? So we ruled out other endocrine dysfunction, ophthalmological examination, hearing assessment revealed normal study. MRI brain showed multifocal subarachnoid bleed with HIE changes, with pituitary hypothalamic region normal, and with an intact posterior pituitary bright spot. In the background of intact posterior pituitary bright spot, we did some literature search where it revealed that greater sensitivity of the hypothalamic neurohypophyseal axis to perinatal depression, perinatal asphyxia compared to other endocrine functions. The probable reason could be due to the fact that supraoptic and the paraventricular nuclei of the hypothalamus is highly sensitive to hypoxial injury. These are few literature study which showed the association of central neonatal diabetes insipidus with brain injury and severe perinatal asphyxia. And an important finding of all the cases reported was that most of the cases had intact posterior pituitary bright spot. There is another postulate according to the Williams textbook of endocrinology, 14th edition. There is 15% cases who had sustained subarachnoid hemorrhage could develop acute central diabetes insipidus. So take-home message was, keep in mind diabetes insipidus while managing hypernatremia in a case of suspected HIE. Meticulous monitoring of urine output in a case of hypernatremia. Thank you.
Any questions from the judges or from the floor? May I request Dr. Ojitis to give his input regarding this case? Is he here?
Thank you, ma'am. This is a very interesting case. Actually, probably 20 to 30 times sodium was done during hospital stay. And actually, we are not so much habituated with hypernatremia. We are more habituated with hyponatremia in ICU settings. But anytime if you see a patient, there is an increasing trend in sodium concentration, we have to have a clear-cut idea regarding the volume status. If it is hypovolemic hypernatremia, we have to first give IV fluid for volume restoration. In this particular case, we have also, at that time, we had given IV fluid initially, then we supplement hypotonic with the hypotonic solution to overcome the intracellular dehydration. But one important point from the endocrinology point of view, we can say that any patient with central diabetes insipidus, our thinking is that posterior pituitary bright spot will be absent. But this is actually a misunderstanding. In the childhood age, particularly if you follow the patient, initially bright spot could be present for a few years maybe. And with follow-up imaging, you will see bright spot will go there will be no bright spot with time. So this is one important learning here. And second is anytime if the patient is taking the oral desmopressin, we have to give sometimes intermittently drug off period, because patient may take extra fluid, and in that case there is a chance of hyponatremia, arterionic hyponatremia, and there is every chance of patient may presented with severe hyponatremia and cerebral edema. So a patient with oral desmopressin in a background of central diabetes insipidus, if complain of headache, if complain of lethargy, drowsiness, first action is there to stop desmopressin and then check sodium. And if the sodium level is going down, then give a proper spacing, maybe 1 day or 2 days of oral desmopressin. Then again you can start with desmopressin, but with a lesser dose, and maybe you can give a proper time interval between the 2 doses. So anytime a patient on desmopressin, you have to have a clear-cut idea regarding the hyponatremic changes. And second is, any patient with hyponatremia, please check urine output, whether the patient is suffering from diabetes insipidus or not. Polyuria is a very important point, and initially we missed it, but after that, when we revisit their case, we saw that the patient is actually suffering from polyuria from the very beginning. Thank you very much.
How long it takes for the central diabetes insipidus to subside?
Ma'am, that is actually it is from the common perception, particularly transient diabetes insipidus occur particularly in the settings of TBI, means traumatic brain injury, or after encephalopathy. Usually they can last for 7 days to 1 week or 2 weeks, but sometimes they may persist for prolonged month, maybe few months, maybe. So in that cases, we have to give some drug-free period. You have to check whether the urine output is again increasing or not. And if it is increasing, that means the process is going on. So you have to continue the drugs. Ultimately, it may land up to permanent DI maybe. And another important point is, in pediatric work, we do see subarachnoid hemorrhage very frequently. But that doesn't mean that subarachnoid hemorrhage will not do any harm. But actually, what happened in subarachnoid hemorrhage may cause central diabetes insipidus. So this is also a good learning. Any patient with subarachnoid hemorrhage, you have to check urine output on regular basis, and you have to check sodium. Subarachnoid hemorrhage may cause hyponatremia by the mechanism of SIADH, but they may cause central diabetes insipidus also. So it can go both ways. So you have to check sodium on regular basis in a background of subarachnoid hemorrhage. That's all from my side. Okay.
Thank you for your input so much. Dr. Ray, do you want to say something?
Good afternoon. Before Tabassum starts, just a couple of quick announcements with kind permission from Indranil. I'm not sure the Indranil is there. Neocon, National Neocon is coming to Kolkata, Science City, 1 to 4 December 2022. Expected more than 3,000 delegates, international speakers, and all Neocon paper presentations and everything will be there. We will have 22 workshops, not in the city, also in the periphery as well, including ventilation workshops and other things. And also there will be a good workshop on point of care ultrasound scan by the Canadian team is coming to NRS Medical College. And in RKM also, we have got a hypothermia workshop will be conducted by CMC Vellore and JIPMAR. So the early bird registrations will soon be over within a couple of days. Please register. And also, Rajiv asked me to announce for him, there is a pediatric bladder group. They are conducting a educational course with international speakers, and the registration fees is 1,000. It will be online and it will be available on the leaflet distributed in the WhatsApp group. Please join. Thank you.
Thank you, Dr. Ray, and thank you, Anuj, for your beautiful presentation. Next, we have Dr. Tabassum Khatun, who will be talking about autoimmunity and infection at crossroads. Good afternoon, everyone. Myself, Dr. Thalassemia Khatun, first year resident of pediatric medicine at Ramakrishna Mission Seva Pratishthan. Today, I am presenting a case of autoimmunity and infection at Crossroad. 6-year-old girl from Bashpala admitted on 17 February 2022 with chief complaint of intermittent fever for 10 days.
একটু direct করো। এই এক সমস্যা ছিল। Stop sharing. একটা করে বারবার
বেলাদি ঘুমের মনে হয় কি বাকি আছে সোমনাথকে বলবে ঘুমের মনে হয় টাকা দেবে
Next call.
একটু পরে এখানে তো 10 মিনিট আরো 3 ঘন্টা প্রেজেন্টেশন নেটওয়ার্ক ইস্যুস হচ্ছে একটু ট্রাই করে দেখতে
এখানে করলে হচ্ছে এটাতে sorry for some technical error. I am continuing. 6-year-old girl from Bashpala admitted on 17 February 2022 with chief complaint of intermittent fever for 10 days, abnormal movement of left upper and lower limb for 7 days, with altered sensorium for last 1 day. Child was apparently well 10 days back, then she developed intermittent moderate degree fever, which was subsided on medication. Fever was associated with abnormal movement, which was slow, continuous rhythmic, mainly distal part of left upper and lower limb, mostly seen during awake time. Also had progressive difficulty in walking and frequent falls. There was history of abnormal behavior. Child was initially restless, agitated, but later become less interactive. There was no history of loose stool, recurrent vomiting, joint pain, rash, oral ulcer, no history of any tongue intake before the episode. Past history was nothing significant, birth history was uneventful. On admission, child was conscious but irritable, vitals are stable except for tachycardia. Patient was afebrile on admission. GCS 12/15, E4, V2, M6. She was unable to communicate, no speech but spontaneous eye opening present. Lip smacking dystonia, chorioathetoid movements in left upper and lower limb noted. There was no signs of meningeal irritation, tone increase in all 4 limbs in form of spasticity, deep tendon reflex exaggerated in all 4 limbs without any clonus. Bilateral plantar extensor, although sensory system could not be assessed properly, but pain sensation present in cerebellar system, we don't found any nystagmus or pendular nature. Other system is within normal limit. This child presenting with chorioathetoid movement in the left upper limb and left lower limb. It asks. So I am summarizing the case.
6-year-old girl, intermittent moderate degree fever of 10 days duration associated with abnormal chorioathetoid movement with gradual deterioration of mental state with human finding. Our provisional diagnosis is acute encephalitis syndrome. Other differential diagnosis is acute disseminated encephalomyelitis and autoimmune encephalitis. On initial investigation, CBC RFT was normal, CRP was negative, CT scan did not reveal any abnormality, fundus examination is normal. CSF study for cell type, cell count and biochemistry normal, gram stain, AP, fungal stain, culture all negative. So we sent paired sample of blood and CSF for IgM of Japanese encephalitis, which later came negative. MPDA scrub COVID RT-PCR also negative. CBNet done from CSF sample and also from sputum was negative. MRI brain was normal. EEG showing non-specific slowing in parieto-occipital region. Clinical course. On day 1, we started treatment as per AS protocol with injection ceftriaxone and injection acyclovir. Oral haloperidol is added as per neurology opinion. Next day, patient was afebrile. Frequency of abnormal movement decreased. On day 3 of admission, child developed single spikes of fever, other vitals are stable. Fever spikes increase, patient gradually becomes drowsy. On day 5, GCS was 8/15 and had one episode of GTCS and became hypotensive. BP was 80/40, less than 15 percentile. So patient was urgently intubated, mechanically ventilated, IV fluid was given, followed by inotrope started. IV lorazepam followed by loading dose of phenytoin given. After initial stabilization, CBC, CRP and electrolyte was sent, blood cells, urine cells repeated, and antibiotic upgraded to meropenem. On repeat investigation show mild anemia, neutrophilic leukocytosis, CRP was highly positive, blood cells of growth of Klebsiella pneumoniae, which was sensitive to meropenem. After treating, patient sensorium gradually improved. GCS was 13/15 on day 7 of admission, so patient was extubated. In the meantime, CSF viral PCR came negative, so acyclovir omitted. We reserved the sample of CSF. As initial CSF screening was negative, we sent for CSF autoimmune panel, which was interestingly came positive for anti-NMD antibody. Although initial COVID RT-PCR negative, we sent COVID SARS-CoV IgG, which was positive. Echo was done, revealed no abnormality. Keeping in the mind of autoimmune encephalitis, we started treatment plus pulse dose of methylprednisolone given for 5 days, followed by gradual tapering with oral prednisone. Due to suboptimal response, we started IVIG at a dose of 2 gram per kg. Patient subsequently improved and discharged. On follow-up, in our OPD, we searched for literature. Although very few cases of anti-NMDA encephalitis with SARS-CoV-2 reported, in which patient presented with acute behavioral and mood changes, abnormal movement, autonomic instability, and seizure and encephalopathy. So our take-home message is patient presenting with fever, new onset movement disorder, abnormal behavior with progressive deterioration of mental state, other than Japanese encephalitis induced acute encephalitis syndrome, we should keep in mind autoimmune encephalitis. There are many known infective triggers such as herpes simplex virus, human herpes virus. We should that may trigger autoimmune encephalitis, but considering recent scenario, COVID could be a potential possibility, although very few cases are reported. Thank you all for presenting this case.
Any questions from the judges or from the floor? Virtually, anybody, please kindly write your questions in the chat box. If no questions, we'll go on to the next case. Thank you, Thalassemia. The next presenter is Dr. Vinay, who will be talking about late night jitters.
Good afternoon, teachers. I am Binoy Mahali, first year PGT of Pediatrics in BIMS. Today I am presenting a case of late night jitters. A 1-month-old male child born of a consensual marriage with a forthcoming mother with a normal antenatal history presented one night at the ER with a sudden onset abnormal involuntary jerky movement of whole limbs for 15 minutes associated with uprolling of eyeball and unresponsiveness. On examination, there was no anemia, no cyanosis, no jaundice, and no edema. And vitals revealed tachycardia with a saturation 92%. No syndromic stigma. Weight was 3.5 kg and length was 50 centimeter. Both were below the first percentile. On other systemic examination was normal. On past history, no such similar episode, no other comorbidity. On family history, there was nothing significant. The baby was immediately transferred to PICU and CBC was 85 mg per DL and face mask oxygen was given. Phenobarbital was loaded at a dose of 20 mg per kg and blood investigation sent and seizure continued. Another half loading dose of phenobarbital as a dose of 10 mg per kg was given and still seizure continued. Then levetiracetam was loaded at a dose of 20 mg per kg and seizure was controlled and baby was put on maintenance dose of phenobarbital and levipil. After stabilization, sepsis screen, blood culture, electrolyte, and CSF study was done. Meanwhile, there was a sudden onset tonic movement of left upper limb, and then levetiracetam was loaded at a dose of 60 mg per kg, and seizure responded partially. Among all reports, corrected calcium was 4.9 mg per DL, which was markedly low, and magnesium was normal. Then 10% IV gluconate was loaded under proper cardiac monitoring. Then seizure stopped. The child was started IV calcium gluconate at a dose of 80 mg per kg per day for 48 hours. Among the other investigations sent, sepsis screening and the initial CSF study were normal. After stabilization on further inquiry, there was no history of prematurity, any cow milk or fortified milk intake, any feeding intolerance, any maternal anticonvulsant, or any maternal seizure disorder. Though baby was present at the age of 1 month, this seemed unlikely the early onset hypoglycemic seizure. Considering the late onset hypoglycemic seizure, we sent the blood for phosphate, 25 hydroxy vitamin D for both mother and baby, and ALP and renal function test and liver function test. On investigation report, calcium was 4.9 mg per DL, which was markedly low, and phosphate was 30 mg per DL, which was markedly high, and magnesium and 25 hydroxy vitamin D, ALP, albumin was normal. So provisional diagnosis of hypoparathyroidism met. On the immunoreactive parathormone, PTH, and urinary calcium creatinine report was calcium creatinine ratio was sent. Then immunoreactive PTH was 3.4 picogram per ml, which was low, and urinary calcium creatinine ratio was normal. So diagnosis of hypoparathyroidism was confirmed biochemically. The child was started on oral calcium with a dose of 75 mg per kg per day and calcitriol on a dose of 0.375 as a microgram per day. Even after oral calcium and calcitriol at a therapeutic dose, the serum calcium was not improving to target level. At the same time, the peripheral intravenous access could not be obtained. The patient party did not give consent for central line, and there was suboptimal response of calcium and calcitriol. So we consulted to our endocrinologist and opined to initiate the subcutaneous teriparatide. After receiving teriparatide along with the calcium and calcitriol, we are able to control the hypocalcemia. Next, we moved to search for etiology of hypoparathyroidism. On physical examination, did not reveal any facial dysmorphism, any skeletal dysplasia, any organomegaly, or any individual marker. There was no cleft plate and no history of choking or nasal regurgitation. Echocardiography and USG abdomen and TOB are normal. USG neck did not develop thymus. So for confirmation, we sent genetic panel for Dijk's syndrome. And this was the genetic panel, but the Dijk's was negative. And Pero was also done, which was normal. And no renal involvement, and Barakat syndrome seemed unlikely. No evidence of metabolic acidosis, including the lactic acidosis. Serum ammonia was only marginally elevated, so mitochondrial cause seemed unlikely. No oral candidiasis. Ultimately, we plan to roll out the familial isolated hypoparathyroidism. The most common genetic defect in familial isolated hypoparathyroidism is the calcium sensing receptor activating mutation, CASR mutation. So we send genetic panel on whole exome sequencing to rule out the CSR mutation or any other associated mutation. Interestingly, genetic panel reveals the GCMB mutation, which is rarest in familial isolated hypoparathyroidism. And this was the genetic panel where the show the autosomal recessive GCMB mutation. The most common cause of familial isolated hypoparathyroidism is the autosomal dominant calcium sensing receptor activating mutation or CSR mutation, and other causes are the autosomal recessive hypoparathyroidism GCMB mutation followed by PTH and X-linked hypoparathyroidism to SOX3. Initial follow-up involved monthly visit with a monitoring serum and uric calcium and uric creatinine. The patient is now 4 months old and has achieved normal milestone for his age and is seizure-free on calcium and active vitamin D supplements. And these are the articles showing the GCMB mutation in familial isolated hypoparathyroidism. A take-home message will be hypocalcemia should always be considered as a possible cause of neonatal seizure, even if the presentation is around a month, when meningitis and metabolic errors are considered more common. And recurrent hypocalcemia should always be investigated thoroughly and the etiology searched for. And teriparatide could be a novel management therapeutic agent, particularly where IV calcium therapy is partially responsive. Thank you.
Thank you, Binoy. Any questions? Ajitesh, you want to say something about this case? Very quickly, please, because we are running out of time.
As an endocrinologist, actually, I have to mention about the teriparatide. It is a synthetic PTH, synthetic recombinant PTH hormone, 1 to 34 amino acid. Actually, it is used nowadays for the treatment of osteoporosis because it increases osteoblastic population, and so it is a very novel agent for osteoporosis. But what happened? There are some reports where if we give teriparatide for short time period, it could be used as a novel agent for hypocalcemia. Particularly in this case, when I saw this case first, there is the multiple channels are there, and it is not possible to go for proper channel, and central line was also not done. So then we plan to give teriparatide injection in that case, and with the help of teriparatide, we definitely we control the hypocalcemic episodes. Second point is that we have to give calcitriol definitely. In this case, always we have to give calcium along with calcitriol. We know that this active vitamin D is formed in kidney, and for that we have an enzyme. This is the 1-alpha hydroxylase enzyme, and this is actually stimulated or inducible enzyme, and the inducible the PTH hormone actually induces 1-alpha hydroxylase. So if there is no parathyroid hormone in your circulation, there will be no active vitamin D. So patient will, in spite of having normal vitamin D, patient actually will be devoid of active vitamin D. So anytime if you treat hypoparathyroid patient, you have to give calcium along with active vitamin D, not only plain vitamin D or calcidol or cholecalciferol. So this is also another important point here. So anytime if you feel this type of problem, you can try teriparatide with a 1 microgram per kg body weight, at least for 7 to 10 days. When patient will be stable, patient can take calcium and calcitriol orally, there will be no problem. So that's all from my side. Yes. No, definitely not. Actually, any hypoparathyroid patient, if they got calcium and calcitriol with the appropriate dose, there will be no hypocalcemia. But initially what happened during rice tube feeding, there is multiple problems arises at that time. So this is the reason why the patient is not responding with the calcium and calcitriol solution at that time. So I think this is not a not so much novel, but in India probably in West Bengal particularly, we have started with the only first time with in neonatal seizure with teriparatide, and patient responded dramatically, definitely. So that's from my side.
Thank you, Dr. Ajitesh. One quick point is when we start parathormone, I think we have to be very careful about monitoring the calcium because suddenly it rises and we can land up with a nephrocalcinosis. Yes, so yeah, we have to monitor that and come down on the calcium, oral calcium doses. So we come to the last speaker for the day, and the next talk is on the changing colors by Dr. Turiyo Adhikari.
Good evening, everyone, my respected teachers, seniors, and my dear colleagues. Myself, Turiyo Adhikari, first year PGT, WIMS. I've got a golden opportunity to present an interesting case titled The Changing Colors. A 3-year-old girl from Kapdi presented at our emergency with fever for last 12 hours. It was high-grade, intermittent in nature. Abnormal jerky movements of all 4 limbs for last 30 minutes. There was altered sensorium with intermittent jerky movements on arrival. The child was admitted in PICU after initial stabilization and injection lorazepam at emergency. There was 2 episodes of simple febrile seizure at 1 year 8 months and 2 years 6 months of age. No other chronic medical illness or previous history of hospitalization. 9-year-old elder brother had several episodes of febrile seizures till 5 years of age and now seizure-free for last 4 years. No family history of epilepsy, mental retardation or developmental delay. The baby was born term, normal vaginal delivery, birth weight was 2.2 kg, cried immediately after birth, no perinatal complication. Developmental history normal for age. On clinical examination, the child was pale. There was 102-degree temperature. On examination of skin, we found papular eruption over face. 1 hypopigmented macule was noted over back. On CNS examination, the GCS was 13/15. Pupils was bilateral equal in size and normal reacting to light. Tone was decreased in all 4 limbs. Jerks was decreased. Plantar bilateral flexor, no signs of meningeal irritation. After initial evaluation, our differential diagnosis were febrile status epilepticus, acute encephalitis syndrome, generalized onset epilepsy triggered by fever, or it could be a case of neurocutaneous syndrome presenting as status epilepticus. Initial management, maintenance of airway, breathing and circulation, moist oxygen inhalation at the rate of 2 liters per minute was started through face mask. Injection levetiracetam loading dose followed by maintenance dose, and injection ceftriaxone acyclovir along with supportive care like fluids, Hollis catheter was started. On admission, investigation revealed hemoglobin was 8.1, CRP was raised 26.7, RT-PCR for COVID-19 was negative. On day 3, repeat CRP was showing decreasing trend with about 3. In view of hemoglobin being 8.1, we did a peripheral blood smear which revealed microcytic hypochromic anemia. So working upon that, incidentally we did an HPLC and we got E-beta thalassemia. CSF analysis was planned as the child symptomatically improved and GCS became 15/15. After ruling out papilledema, guarded LP was done. CSF was cytologically, biochemically normal and no microorganism could be detected on gram stain. CSF PCR was negative. MRI blend showed subependymal nodules and a giant cell astrocytoma in frontal horn of left lateral ventricle. I can point the marker here. That was our first clue. Are we dealing with a case of tuberous sclerosis presenting with status epilepticus? So we searched for other organ involvement. EEG was done, it was normal. Echocardiography was done. Two rhabdomyoma about 19 into 5 millimeter noted at left ventricle. USG kidney uterine bladder, small ill-defined hyperechoic lesion about 14 into 10 millimeter at upper pole of right kidney, possibly angiomyolipoma. Direct ophthalmoscopy was done. It revealed calcified retinal hamartoma. Further course, the child became afebrile from day 3, but on day 6, the child had fever again. Oral mucosal congestion was there. There was diarrhea and bradycardia. Hemoglobin was 7.1. There was TLC was 8,200. CRP was negative. So we sent for SARS-CoV antibody, which came out positive. Inflammatory markers like ferritin was 350, LDH 623, D-dimer 1455. Echo was repeated, which showed right coronary artery dilatation about 3.6 millimeter with a Z-score of 5.13. So now our provisional diagnosis is MISC KD phenotype in a case of tuberous sclerosis. We started on IVIG and followed by injection methylprednisolone for 5 days, then dexamethasone for next 2 weeks. Aspirin was continued. So we modified our final diagnosis like a child with severe MISC with right coronary artery dilatation, tuberous sclerosis presenting with status epilepticus and E-beta thalassemia. The child was discharged on day 12. The child is seizure free since discharge. On follow-up, echo showed improving coronary dimension. The child is planned for genetic evaluation and neurosurgical consultation. Elder sibling also planned for follow-up. Just a brief discussion, the major morbidity and mortality in tuberous sclerosis is neurological and renal manifestation. So subependymal giant cell astrocytoma are detected in about 5 to 10% of cases. Medical management of SEGA is everolimus at the rate of 5 mg per square meter body surface area. Neurosurgical resection of SEGA is indicated in refractory seizure, obstructive hydrocephalus, and rapidly progressive tumors non-responsive to everolimus. Renal angiomyolipoma management is also by everolimus. Embolization of segmental artery in acute hemorrhage and rarely by segmental resection of kidney. Just a brief diagnostic criteria on what we found in our case. We found one hypomelanotic macules. There was one shagreen patch on lumbosacral region. There was multiple retinal hamartoma. There was subependymal nodules, subependymal giant cell astrocytoma on MRI. There was 2 cardiac rhabdomyoma. There was angiomyolipoma on both kidney. Just the take-home message, every patient with febrile status epilepticus should be evaluated thoroughly. MISC may complicate other disease states. In post-COVID era, we should be cautious and keep MISC as a possibility always if clinically suggestive. Echocardiography is mandatory and may prove life-saving if MISC is diagnosed. In a case of tuberous sclerosis, developmental delay and abnormality of EEG may not always be present. Regular follow-up of patients of tuberous sclerosis and seizure control are essential. Everolimus and neurosurgical intervention is indicated in some cases. So my references, Nelson's and Swyman's, and thank you.
Thank you, Turio, for that wonderful presentation. Any questions, please? Shudvadi, any comments about the cases so far that you have heard? I'm so glad that at least you could have been present here. Otherwise, the attendance have been very poor because of the heat, I think. So any last comments?
All cases were excellent and the presentation was very good, and we also learned many things. from these cases. And it is good that you could evaluate so thoroughly and ultimately come to a diagnosis with some positive outcome. But one has to be the leader. All unique for the competition sake, one has to be the leader. So I want Nita to declare the name.
Thank you for your comment, ma'am. And give us a few minutes to just quickly calculate all the and find out who's the first in among. I think all of them have done a marvelous job. Very short time they have presented. Thank you to all the PGDs and all the consultants and the mentors who have guided them over the last 2-3 weeks. And a special thank you to Dr. Ryan Dashgupta, who has helped me put this thing together. And thank you once again. May we just have the quick announcement of who is become the first. Do we have the name? Thank you.